Hi, Dr. Brian Kaufman, the Chief Medical Officer, Executive Vice President of the nonprofit CLL Society. Dr. Munir?
Hi, thanks, Brian. I'm Dr. Munir. I'm a hematology consultant working at St. James's Hospital in Leeds. My research interest is CLL, and I'm a hematologist based here in UK. Many thanks for asking me to talk.
Tal, Leeds has led much of the research going on in the United Kingdom, and some of that's been breakthrough. And one of the big trials has been the FLAIR trial. And if you could just kind of set the stage, and then at the American Society of Hematology annual meeting, or ASH 2021, you presented what I thought was really remarkable and, to me at least, surprising data on the cardiac complications and sudden death associated with Ibrutinib, and a possible significant risk factor for that. So maybe you could set up by reminding us what the FLAIR trial was, and then what you found related to Ibrutinib and hypertension and cardiac death.
Thanks, Brian. So FLAIR trial is the biggest phase 3 trial for CLL. And we have been conducting this study since 2014. And in the initial part of the study, we had only 2 arms, in which the standard arm was chemoimmunotherapy in the form of FCR. And then we had the investigational arm, which was Ibrutinib with rituximab arm. So the data that I've presented at ASH looking at this finding was primarily looking at the Ibrutinib rituximab patients treated on the experimental arm of the study. And my colleague and co-author, Professor Hillman, presented the efficacy data at an oral presentation. We do have 2 other arms in this study, which is Ibrutinib only arm, and then there is a Ibrutinib with venetoclax arm on FLAIR study, and we are hoping to present the data next year. What we have looked at in this analysis was looking at the low numbers of cardiac deaths that have been reported in multiple phase 3 trials now. And a lot of those reports have been looking at either cardiac deaths or sudden unexplained deaths, or sometimes ventricular arrhythmias with Ibrutinib, but the numbers have been very small.
So remind us what a ventricular arrhythmia is. Could you explain that for a patient? Yeah.
Yes, so ventricular arrhythmia is an abnormal rhythm in the ventricles of the patient. So this is going into very, very abnormal rhythm. And the consequence of that is that the heart is unable to pump the blood out, and majority of the ventricular arrhythmias are undetected. So one of the concerns with this kind of arrhythmias is that the unexplained deaths or sudden deaths might be associated with ventricular arrhythmias. And this is something which is being talked about, and there have been case reports and about very low numbers of these kind of events happening. So what we wanted to look at, whether in our study where we are monitoring the patients closely, whether there is a difference between the chemoimmunotherapy arm and the Ibrutinib arm of the study. And what we looked at was how many patients on the Ibrutinib rituximab arm had hypertension, high blood pressure, or they were on blood pressure pills before they entered into the study. And then we looked at both arms of the study and wanted to make sure that our comparison is equal between the 2 arms. So I would expect that when the patients go into either FCR arm or Ibrutinib rituximab arm, equal number of patients might have hypertension, and they might be on the same drugs. And then we try to analyze if there are more cardiac deaths happening or sudden deaths happening in the Ibrutinib rituximab arm of the study. So that was the primary analysis. And then we tried to look at, is our data concordant with other large phase 3 studies, and we did a meta-analysis to look at that as well. So we found that the treatment at baseline with all of the drugs used for high blood pressure, like ACE inhibitors or angiotensin receptor blockers, were pretty similar in both arms of the study. And the patients who had high blood pressure, nearly 1 in 5 patients had high blood pressure in the FCR arm, and same was about ibrutinib rituximab arm. And the numbers were pretty much similar in both groups, suggesting that our analysis was pretty similar in both arms of the study. And what we found in terms of the results was that the relative risk of somebody dying from unexplained or cardiac death in the ibrutinib rituximab arm was nearly 18 times more likely in those with a cardiac disorder at trial entry than without. So that means that if you had a cardiac problem before you went into the study and received a ibrutinib rituximab arm, there is a higher chance of getting a problem. And again, the same association, whether you were on a drug called ACE inhibitor at trial entry or not. So this does tell us that the relative risk of getting a complication on ibrutinib was high. And then we did a meta-analysis and looked at all the phase 3 studies like ALIGN study, ECOG 1912, ELIMINATE study, and these are various studies where ibrutinib has been used, and actually found that FLAIR is not an outlier. We found that most of the studies fall into the same pattern, whereas the only outlier was the ECOG 1912 study. But we know that in patients who went into that study, the median age was only 56. So this was really a younger age group, whereas our trial had a median age group of around 63, and nearly about more than 20% of the patients were above the age of 65. So it is an interesting finding. We will have more data on the other ibrutinib containing arms on FLAIR study, and we would be able to present that, hopefully that data next year, so that we have better clarification of which are the best patients to use ibrutinib and the complications associated with that.
What I found interesting was, and at least the way I read it, is the ACE inhibitors, which are very commonly used to treat blood pressure, seem to be particularly higher risk compared to other drugs like a diuretic or a water pill or a beta blocker, which is like an anti-adrenaline type, or even the ACE receptor blockers, the ARBs. Is that a correct understanding? And do we have any sense of why that might be?
So that is exactly what we found as well. And one of the outcomes of this analysis was that we presented this data to FDA as well. And there is obviously a label to use ACE inhibitors with caution. The only caveat to that, and I'll be clear about that, is that for high blood pressure, ACE inhibitor is one of the best tablets you can use. And one of the issues is that we've got far more patients on ACE inhibitors in this study as compared to the other drugs that we use for hypertension. So the numbers are not high enough for us to make a very definitive conclusion. And the second thing is that it's not surprising that the people who have got hypertension or a cardiac disorder would be on this drug. So dissociating ACE inhibitor and hypertension is quite difficult to do. And that is a very difficult analysis, which needs more numbers. And hopefully when we get the data from our ibrutinib and ibrutinib with venetoclax arm of the study, then we would have a better explanation of what's happening here. But one of the kind of conclusion is that there are caveats to this analysis, but it is an intriguing finding that we had to put out to our trial participants to say that it is preferable that you change your ACE inhibitor to another drug, so that we can mitigate the risk as much as we can.
Any final thoughts on this finding or this research? I can't wait to see what the rest of the data shows, but this is certainly, I think, at least at this point, an actionable outcome for patients if with their doctors consider that if they have another option than an ACE inhibitor, to consider that. Yeah.
Yeah, no, I think, yes, we have got this analysis which has come out, and I think we are going to make it more robust with more numbers in near future. But I think the take-home message at this moment in time is that one, people who have got high blood pressure or on cardiac meds, they need to be properly analyzed before they receive Ibrutinib. And no, in our trial, we get a heart scan called echocardiogram in those patients, which was not a prerequisite before. And we also, if there is a concern, we ask a cardiologist to see them before we get patients onto the study. The other thing is we have asked our patients to switch therapy. Whether that's the right thing or not at the moment, we will get that data in near future. But I think because we found this finding, we had to report it and we had to take action on it.
Tal, thanks again for what you're doing and what you're doing for the CL community. And I look forward to your continued efforts to try to unwind these things and help us. Thanks so much.
It was my pleasure.